Nomogram to predict lymph node metastasis in patients with early gastric cancer, a useful clinical tool to reduce gastrectomy after endoscopic resection. Introduction. Although radical gastrectomy with lymphadenectomy is the standard treatment for gastric cancer, many patients experience postoperative morbidities. For instance, gastrectomy with lymphadenectomy can cause post-gastrectomy syndrome, which includes delayed gastric emptying, reflux esophagitis, anastomotic leakage, bleeding, stricture, or anemia. These side effects lead to a poor quality of life postoperatively. Endoscopic resection is increasingly used worldwide as a minimally invasive therapy to avoid poor outcomes after gastrectomy with lymphadenectomy and improve the quality of life of patients with early gastric cancer, EGC. Endoscopic submucosal dissection, ESD, is performed in selected patients with diagnostic endoscopic findings. The Japan Gastroenterological Endoscopy Society and Japanese Gastric Cancer Association have suggested that differentiated type EGC confined to the mucosa without ulcerative findings and with a tumor diameter 2 centimeters or less is an absolute indication for ESD. The expanded indications for ESD include mucosal gastric cancers of the following categories: A. Differentiated type, ulceration negative, diameter greater than 2 centimeters. B. Differentiated type, ulceration positive, diameter 3 centimeters or less. C. Undifferentiated type, ulceration negative, diameter 2 centimeters or less. If the pathological findings do not meet these indications after ESD, the patient should undergo gastrectomy. Subsequent gastrectomy was reportedly required in 0.9% of patients with absolute indications and 19.2% with expanded indications. Residual cancer and lymph node metastasis, LNM, were detected in subsequent gastrectomy specimens from 5.6% to 11.5% and 7.5% to 16.7% of the patients respectively. Therefore, with the accurate prediction of LNM, it may be possible to avoid unnecessary gastrectomy after ESD. Studies on the risk factors for LNM of gastric cancer would provide additional information. However, this may not be achievable. Presently, a nomogram is a precision tool that enables patients and clinicians to predict the probability of survival or LNM in the perioperative period. It also provides personalized, quantified information for various carcinomas. In gastric cancer, several nomograms have been introduced to predict postoperative outcomes, including complications and survival. A nomogram may also be useful for predicting the probability of LNM and identifying those patients who should undergo gastrectomy. This study aimed to develop and validate a nomogram with the goal of developing a more predictive tool than the ESD indications for identifying LNM and ultimately avoiding unnecessary gastrectomy in patients with EGC. Methods. The authors reviewed clinico-pathological data from 10,579 patients who underwent curative resection for EGC. The nomogram was developed by multivariate analysis and was evaluated by external validation. Overall disease-free and recurrence-free survival were compared between the gastrectomy group of 6,641 patients and the endoscopic dissection group of 999 patients to show the efficacy of the nomogram. Results. Multivariate analyses revealed that age, tumor size, lymphatic invasion, depth of invasion, and histologic differentiation were all significant prognostic factors for lymph node metastasis. The nomogram had good discriminatory performance with a concordance index of 0.846. This was supported by the external validation point of 0.813. For patients with low risk of lymph node metastasis on the nomogram, 3% or less of the provisional value in this study, the endoscopic dissection and gastrectomy groups had comparable rates of overall, p equals 0.32, disease-free, p equals 0.47, and recurrence-free, p equals 0.09 survival. Conclusions. Soo-Mi Kim et al. Developed and validated a nomogram that predicts the risk of lymph node metastasis in EGC based on a large database. This precision nomogram is useful to avoid unnecessary gastrectomy after endoscopic dissection, which may ultimately improve the quality of life of patients with EGC.